A very good afternoon to everyone. Before we proceed to the announcement of your best oral and best poster presentations, let us end all presentations with a very familiar topic to everyone, the COVID-19. I am Dr. Joe from School of Medicine, and I would like to congratulate everyone who took part in this year's symposium. Thank you and congratulations, Ms. Celine Chu, the chairperson, and to our program director, Dr. Ma. The title of this presentation is Understanding the Epidemiology of COVID-19. Critical to the prevention and control of COVID-19 is the characterization of its epidemiology. Let us start by defining epidemiology. The word itself comes from the Greek epi, demos, and logos. Literally translated, it means the study of what is upon the people, or what befalls a population. It is further defined by John M. Last as the study of the distribution and determinants of health-related states or events in specified populations, and the application of this study to the prevention and control of health problems. The definition underscores that epidemiologists are not only concerned with disease but also with health-related events, which may also include injuries, accidents. I highlighted in red the big words here, distribution and determinants, and we will examine that later on. Of course, the application of this study is also highlighted because this is the main purpose why we are all determining all this. It's for the prevention and the control of these problems. Thus, epidemiology is considered as the cornerstone of public health because it shapes public health policy decisions and the medical practice. Distribution refers to analysis of the occurrence of disease. It is the frequency and pattern of disease occurrence. Frequency refers to the number of health events and its relationship to the size of the population. This gives us the rate of the disease, allows epidemiologists to compare disease occurrence across different populations. Pattern refers to the occurrence of health-related events by personal characteristics, place, and time. The premise underlying epidemiology is that diseases or health problems are not randomly distributed in human populations, and it changes over time. Now, determinants are the causes and other factors that influence the occurrence of health-related events. Distribution, in a sense, answers the questions what, who, where, and the when, while determinants answers the why and the how. Thus, epidemiology is further divided into descriptive and analytic. Descriptive focuses on identifying and reporting both the frequency and pattern of health events in a population, and it is evaluating trends, health status, new diseases. We also evaluate existing public health programs. While analytic epidemiology, on the other hand, focuses on the search for the causes or risk factors of health problems. It aims to research and study risk factors and protective factors for diseases. So though we have to take note that epidemiology is rarely able to provide experimental proof in the sense of Koch's postulate, as can often be done in laboratory sciences, it often provides an accumulation of increasingly convincing indirect evidences of a relationship between health or disease and other factors. So that's how epidemiology do this. They build a convincing case that this relationship is causal through the strength of association, utilizing statistical probability and risk ratio, the consistency of findings across multiple studies, temporality where outcome follows causation, and of course, the ability of the observed relationship to correctly predict other relationships. These two components or scope work together to increase our understanding of the health of the population. Now, let us use the science of epidemiology in understanding our current situation. The COVID-19 travel recommendation by destinations released by CDC was based on the incidence rate of COVID-19. That's the new case over the past 28 days per 100,000 population. So for Malaysia, in the past 28 days, we are averaging 6,000 in a day. So get the sum, divide by the total population of this country, multiplied by 100,000, you will get 500 plus cases in 100,000 population. Thus, we are rated level 4 with very high level of COVID-19. So the recommendation, travel to Malaysia should be avoided, and if necessary, the traveler must be vaccinated. However, recently there was a decline of cases. It is now down to 4,000, and if it continues to be at that level in the next 28 days, then we can be rated as low as level 2 or moderate level of COVID-19. Let us look at another important measure, the case fatality rate, or in layman, this is the severity of the disease or how deadly COVID is. CFR or case fatality rate is the proportion of people who die from a specified disease among all individuals diagnosed with the disease over a certain period of time. So the formula for COVID, specific for this disease, number of COVID-19 deaths divided by confirmed COVID-19 cases multiplied by 100. Now, looking at this formula, we may actually overestimate the case fatality rate since we cannot really know the total number of cases. Not everyone is tested for COVID-19, so the total number of cases is higher than the number of confirmed cases. So whenever there are cases of the disease that are not counted, the probability of dying from the disease is lower than the reported case fatality rate. But having said that, we can still use what we have and compare it across different regions. So looking at this graph, case fatality rate of COVID-19, we can see that CFR could range from 1.5 to 3%, meaning out of 100 people diagnosed with COVID, 2 to 3 will die from the disease. And that information will be very useful in building public health policies. Now, in comparison with SARS-CoV-1, MERS-CoV, and Ebola, if all this estimation here is right, then we can say that COVID-19 has a lower case fatality rate. However, we all know that we have to closely monitor and prioritize COVID-19 because it has now covered almost the entire globe, except for some island countries in the Pacific and Atlantic Oceans, and are likely experiencing the benefit of bordering only the sea, and also two non-island countries, North Korea and Turkmenistan, who did not report any case. So the case fatality rate may be low, but because of its high transmissibility, it caused more deaths. Let's look at this graph to understand that further. So this year, the Delta variant is wreaking havoc across the globe in spite of high vaccination rate. And that's because the vaccines manufactured last year was intended for the original strain. And we all know that. But that's beside the point. I want you to look at the comparison between the more lethal strain and the more transmissible strain. So this is a hypothetical scenario showing a number of new deaths every 6 days from 3 different virus strains, assuming each strain started from 10,000 infections in an unvaccinated population. So we can see that although the more lethal strain causes more deaths, the more transmissible strain quickly outpaces it due to the exponential growth in the number of infections. And that is the problem with Delta variant. Let's examine what happens to the real world with high vaccination rate. Let's look at United Kingdom. We all know that UK had a rapid rollout of COVID-19. And according to published reports, cases now driven almost entirely by Delta strain. So if you're going to look at the daily new cases, from December, the daily cases declined, and you can see the dip here from April to June, but sometime July, cases started to soar, and this is also the time when they lifted the restriction. No mask, no social distancing. And this surge continues up to this present day, despite of a high vaccination rate. But what I would like you to note is actually the daily deaths graph here, the daily new deaths. In spite of the surge, the death is still kept below 300 in a day, in comparison to the previous surge. Now, there's the first spike here. You may ask, how about this? When cases reported is actually low. Well, we can interpret that case fatality rate may be high during this time, but this is what I have mentioned earlier, that we may overestimate the CFR if we don't really have the exact number of cases. And that's what usually happens at the start of the pandemic, when we don't have the diagnostic facilities yet. And it can also happen when the virus mutates and existing diagnostic tests are not able to detect it. The same trend is observed in Germany. There is a recent surge in COVID in Germany that's also driven by Delta, but look at the deaths. That is still kept below 500 in comparison with the earlier spikes. So with all of this information, we can say that COVID-19 vaccine we have now is still effective in the real world, preventing hospitalizations and death. And that negates now the hypothetical scenario on vaccinated or unvaccinated people where there will be more deaths because of increased transmissibility. Let us examine that further using published report. Effectiveness of COVID-19 vaccine against the Delta variant. So effectiveness after one dose for both vaccines, it is lower in Delta, 30.7. Same thing with Pfizer alone, 2 doses, it's lower, 88%. And also in AstraZeneca, it's lower at 67%. So generally, the effectiveness is lower with Delta strain. We can see that also applies in our local data. So if you can see, fully vaccinated makes up the 26% of those cases. and partially vaccinated 19.1%, though majority or major bulk is from the unvaccinated group. So, looking at the patterns of COVID-19 occurrence by time is actually critical for monitoring the occurrence in the community and for assessing whether the public health interventions really made a difference. Another pattern that we can look at is the pattern according to place. So describing the occurrence of disease by place provides insight into the geographical extent of the problem, and the most important info we need now is the geographic variation. So as what you can notice here, as we compare Malaysia with these high-income countries where vaccination rollout was very successful, they have controlled COVID cases for some time, but there was a sharp increase of cases. So there is a dip. So this is Australia, this is United States, United Kingdom, and this is Israel. So as we watch other countries and compare, it can give us a warning and guidance on how to move forward. What could be the possible reasons why all of these countries have a sharp increase of COVID cases? This health policy paper has presented lessons that can be learned from 9 countries and regions about the complex and challenging task of easing COVID-19 restrictions. It involves 5 in Asia-Pacific region, Hong Kong, Japan, New Zealand, Singapore, and South Korea, and 4 in Europe, Germany, Norway, Spain, and the UK. According to the authors of this paper, easing restriction is something that should be managed with great care and continued vigilance due to the enormous potential for resurgence if comprehensive safeguards are not in place. Another pattern that we can investigate to help us understand this pandemic is the pattern according to personal characteristics. So this is the result of a systematic review and meta-analysis of mortality data from February 20 to May 21, 2020. So the results reveal that COVID-19 male patients were associated with significantly increased risk of mortality compared to females. Patients with age 50 or more were associated with 15.4-folds significantly increased risk of mortality compared to patients with less than 50. And comorbidities were also associated with significantly increased risk of mortality. COVID disease, cardiovascular, respiratory, diabetes, hypertension, and cancer. And this is also seen in our local data. We have the same findings. Those with more than 50 years of age, male gender, and with comorbidities are at higher risk of dying from COVID-19. And that actually shaped the policy making and health intervention of the global leaders. That's why they have prioritized the elderlies and those with comorbidities in the vaccination rollout. And that now brought an impact to the incidence of COVID-19 cases for this year. Since we are still waiting for the vaccination for our kids, there is now an increasing evidence of higher incidence among our kids, a greater proportion from this population. So this data is from Europe. So according to the National Case Control Study in UK, children under 10 years of age are more vulnerable to Delta transmission by household contact than people aged 30 to 39 years. Another study is a concerning development of a high prevalence of infection in children. The highest burden of infection was in young adults, followed by children aged 13 to 17, children aged 5 to 12, and these rates are actually up to 5 times as high for people aged 65 years or more. The third study examined the risk of Delta variant by age, and it revealed that 5 to 12 years of age are 2.61 times as likely to be infected as people aged 35 to 44 years. And this is similar with USA findings. This graph shows the COVID-19 weekly cases per 100,000 population by age groups. As we look closely from April 2020 to October 2021, you can see that there was a shift of the age group with the highest incidence. In April 20, we have the highest incidence among those more than 75 years old. And in October 2021, it has changed. We now have the younger age group as low as 5 years old. This rise may be attributable to the high vaccination rates among adults in the United States. And that finding is actually consistent with what we have in our local data. There is a higher disease occurrence now from the age group 0 to 11 years old. So the pattern is similar throughout the globe. These trends might be due to Delta's high transmission rate and the fact that many adults are now protected by vaccines. And not to forget that as vaccinated adults, we can harbor the virus without the symptoms and pass it on to our kids. For now, there is no clear evidence that children are more vulnerable to or more affected by Delta compared with earlier variants, but SARS-CoV-2, like all viruses, is constantly mutating and becoming better at evading host defenses. And that could make understanding childhood's protective benefit more important. So while we are still yet to advance our knowledge on all this, we should not wait for a higher fatality rate for our kids. We need to be vigilant. We should think of better strategy in protecting our kids, especially now World Health Organization has recently announced a new variant of concern, Omicron. So in summary, the Centers for Disease Control and Prevention has issued a Level 4 travel health notice for Malaysia due to COVID-19, indicating a very high level of COVID-19 in the country. COVID-19 is not associated with the highest case fatality rate compared with other emerging viral diseases such as SARS, MERS-CoV, and Ebola. More infectious strains can cause more deaths than more lethal strain. Europe is now experiencing COVID surge due to Delta variant. Despite the surge, daily death rates have remained relatively stable compared with the past spikes. Easing restriction is something that should be managed with great care and continued vigilance due to the enormous potential for resurgence if comprehensive safeguards are not in place. Current vaccines are less effective against Delta variant, and children are starting to make up a larger proportion of reported COVID-19 infections. So as we move forward and face 2022, we should take all this, especially now that this new variant of concern is in circulation in more than 10 countries. Australia, Belgium, Botswana, Britain, Denmark, Germany, Hong Kong, Israel, Italy, Netherlands, France, Canada, and South Africa. World Health Organization made that announcement early because of the multiple spike mutations of Omicron. And as we study the three-dimensional image, we can clearly see that the Omicron variant presents many more mutations than the Delta variant, and it is concentrated above all in one area of the protein that interacts with the human cell. I'm not going into micro level, but the point here is that the circulating antibodies that we have right now in our body might not be able to neutralize this variant because of the multiple mutations. We don't know. We're not sure of that. Research is underway. And we have seen that in Delta variant, though, the effectiveness has decreased. Countries who have once controlled COVID cases have experienced COVID surge. And that is sad. That is sad news. But the way how to combat this upcoming variant is to be always on the alert and not to put our guard down. Because unless all countries around the globe have equal access to this vaccination or medication at the same time with other healthy nations, we cannot end the pandemic. It is still far from over. Variants will pop up one after another anytime. And the main message I would like you all to take home is, please, don't let your guard down. A very good afternoon, and thank you, everyone.